as a guest with all my friends. And we were invited here to introduce some of the work that we have done. Yesterday, we were introduced to some of the work that is done in Mongolia, and we were completely blown away. It's really far outreached our expectation. What has happened over the last decade? Well, over the last decade, we have moved from a pre-industrial society to an industrial society to a post-industrial society. And the health panorama has changed. It used to be killing one another and getting infectious diseases. That was the real killer. And then we started to live a bit longer, and then suddenly it was cardiovascular disorders and cancers, etc. And nowadays it's all about promoting health and being able to take care of chronic disorders in order to prevent the industrial era diseases. We're all over in the other corner. Mongolia is right now in the choosing the path. And I think this e-health initiative that we were presented with yesterday is a really promising. So there are some simple rules for success when you want to do systematic healthcare delivery. And it's like anything that you organize. Know where you are and know where you want to go. So get a grip on public health. We were really impressed to see the efforts in public health information that you have here in Mongolia. Share the knowledge. See to that all of healthcare knows what's going on. And then build quality systems for immediate feedback. It's difficult to give an order to a big complex system, but if you give them the right information, they will absolutely do the right thing. And that's what we see. See if it moves forward. Yes. So, and what we saw yesterday is that you have a very reasonable statistical quality, and you have also now the effort in knowledge building. And everybody's convinced that if we give the politics the right numbers of good quality, they will also make the right decisions. And that's an important issue here. We have to go together with politics and profession and the patient needs if we want to go somewhere. Next slide. And knowledge sharing within profession, that's really one of the strong parts in e-health that we are discussing. If we do not share the knowledge and let everybody do whatever they like, we will not reach the good quality. So e-health, and specifically what I've been working on, namely patient outcomes and also care plans that are shared, means that we can actually provide a better quality healthcare service. So this is the idea that we are working with. And the idea is very simple, that the patient is on top. The patient has different information circles with e-health, with the doctor, and with the health system as such. Those information circles can be analyzed, they can be quality documented, and above all, in order to work, they need to speak the same language. So we need the terminology, and we need also the planning to be based on a common language. That's the real trick. The trick is not getting the e-health to talk to one another. The trick is to get all the e-health services to be services and not problem. We saw yesterday that we share some challenges. We saw healthcare, people working in healthcare providing information, the same information, both to a piece of paper and to a computer. That's not an e-health service. That's a e-health pain in the neck. We need to really have services that are integrated in the way we think and the way we plan. Next slide, please. We shared it between 40 different open care, or primary care centers and 4 specialist care centers. And we just had a simple 5-step rule that we had to go through with every patient that had a suspicion of having cardiac congestion, and then optimizing each patient according to a program. And over the course of 4 years, you can see the middle one there, the readmissions to inpatient care decreased with 13%. And what happened? The patients were happier, the people in healthcare were happier, and from an economic point of view, we invested $2 million and came back with $23 million in return with lower costs for healthcare. So by being systematic, knowing it takes education to move forward, it takes understanding to move forward. We knew that we now know that this is reachable in other disorders. And looking at the ambitious plans of the Mongolian government and the World Bank and the Onom Foundation around the problem of blood pressure, being able to follow that up over longer time, I think the goals are enormously ambitious, but I know they are reachable. Next slide. So how do we do that? Well, each patient is a trajectory. Something happens over time. Over that time, you have a history. That's what we have in our e-health records. And we have the now, which is when we meet the patient. The problem is, so far, healthcare has had very little idea of how to share the future vision around the patient. That's what we call care plans. And being able to share the idea of what's going to happen, that's really the core issue of being successful in preventive medicine. And by all means, the ambition that we have seen, we would like to help, we would like to assist. It's just a wonderful plan that we are seeing. So we're really proud to be invited, and as I said to my hosts yesterday, this is great. We're here to listen. Thank you for inviting us. So anyway, once again, I'm really grateful to be here, and I'm really grateful for the presentations that we just had, giving us much more insight of the plans and the capacity building that's going on here. So once again, to own the future, you also have to own the technology, and you have to own the management of the technology. And the ability to scale also in places where capacity and competence is yet to be built is really something that takes time and effort, and a coordinated effort. I'm going to discuss today some different concepts of healthcare, like outcome measures. That is measuring what healthcare actually provide in terms of health and well-being. And the concept of value-based healthcare. I think we have seen one of the world's best examples of value-based healthcare here in Mongolia with the hepatitis program. Actually providing good health in a coordinated measure where you can actually calculate the results. A good thing to drive whatever healthcare does is the patient's voice. And the patient voice should not be something like any ordinary question. It should be an organized effort to really get the information from the patient. And the concept of patient-reported outcome measures, PROM, is a central thing when you really want to know if the population accepts healthcare, appreciates healthcare, and are really also abide to the advice from healthcare. The concept of general health becomes more and more important when you leave intervention-oriented healthcare and goes towards health promotion type of healthcare, what I discussed before as the post-industrial model. And the concept of using processes in order to share healthcare, that's also going to be a theme of what I'm talking about. You remember this slide from before, just emphasizing that since the patient has a very difficult world to try and understand, if we want to give information and health advice to a patient, we need to give a coordinated information, have to have a coordinated information effort. And that means that the same information has to go via the e-health tools, as does from the doctor's orders, as it does from the sort of general public health instructions. I was lucky to be part of the initiation of a coordinated effort to provide a world standard for how you measure healthcare outcomes. We started in 2011 and 12, and now we have some 600, almost 700 international healthcare providers that actually use these standard measurement sets for different diagnoses, whereby you can determine the quality that healthcare delivers. It has turned out that this has been extremely effective for transforming a healthcare system. The resistance from healthcare to change dissolves when the patient voice is coordinated towards the change. One of the problems that we have is that in the head of the doctor, there are many things that happen, and one of them is that they have to make decisions. Yesterday we saw a primary care center where every doctor saw 70 patients every day. That means about 70 times 20 decisions taken every day. And those decisions can be made by routine, they can be made by knowledge, and they can be made also based on too little or too much information. So we really need to help the doctor to take the right decisions. Because the decision space, as it's called in decision science, in the doctor's head, contains information from the patient's background, different forms of contextual information, different measures that have been taken, or studies of the lab tests, etc. And all that goes into the decision space. But also healthcare practices, like what we have measures, what type of decision does it give me to do even more investigations? And also, if the patient has different wishes, etc., that also changes what the decision is made. This complexity in the doctor's head creates one thing that is very important, namely variation in practice. And variation in practice means that half of the patient get a better healthcare than the average, and the other half get a worse outcome than average. And we need not only to improve the general practice level, but we also need to decrease the variation in practice. One way of doing that is trying to understand what decisions are. Decisions aren't magic. Decisions should be made on good information. So trying to move from implicit knowledge, i.e. the doctor as a magician, to explicit knowledge that we can describe, in explicit knowledge representation. By doing that, we can actually improve healthcare quality. The old type of e-healthcare tools, the electronic medical record, the EMR, is only looking backwards, seeing what has happened, and then the doctors still have to make all the decisions. The modern e-health tools, they provide a plan for the future, i.e., it's possible to provide what we call a health service support, also in terms of decision making. That means that you can reserve the real professional decisions to where you really need the professional's advice, and not in the small decision that creates just routine, boring work and where you risk variability. This is the reason why the idea of a healthcare plan that is shared among professionals is one of the most important future tools to improve healthcare quality and to share knowledge between service levels, the primary care, the secondary care, the tertiary care, but also sideways between town and country, between different regions, because the patient may travel across the whole system. Then again, we have what happens in the patient's head. In the patient's head, they have different goals, they come from different places, they want to know different things. So we need to ask them, but we shouldn't ask them in random. We should ask them with science-based tools that are effective in actually mirroring the patient outcome and the patient value. To ask the patient means also we have to understand there are many dimensions that you need to focus on. You need to look at the diagnose specific health with the diagnose themselves, with the activities of daily living. The subjective health, how do you feel? And the healthcare experience, all of that needs to be mirrored. If you combined patient-reported outcome measures with the healthcare own, the way healthcare describes its own success, then you can get a really good measure of what quality has been delivered to the patient. But if everybody used the different measures, we can't compare. So the ICHOM idea is that everybody should use the same measures. And the ichom.org, you can find it on the net, it's a free for everybody to use effort. So anybody can use those types of the standard sets that we have published. It's now possible to mirror really what healthcare provides in terms of quality and do it and get these measures free of charge. Because we have one problem in healthcare, and that is that it's one department that deals with the economy of healthcare and another one that deals with the success of healthcare in terms of what we should do. So if you, this is sort of the incentive map of current healthcare, meaning that the patient pays somebody, that pays somebody who provides healthcare, that pays the healthcare professionals to provide healthcare. But the knowledge structure is totally outside the payment structure. So the knowledge structure is really tied towards the academic influence. So the doctor was taught by somebody 30 years ago, who in turn was taught 30 years ago about what healthcare should be all about. So this model will actually provide a healthcare that is not really modern. And in order to be modern, we need to improve the knowledge building in healthcare. And one of the most important sources is the PROM, namely the patient-reported outcome measures. So the ICHOM has put itself in the knowledge provision, providing information to the patient of what should be asked of the patient, that then gives information, the reported outcomes, back to the payers, the providers, and the profession. And it turns out that this is a very strong driver for change of healthcare quality and diminishing of variability in practice. And in healthcare, there are a number of different stakeholders. There are the payers, they want lower cost. There is the profession, they want to do fancy stuff with technical things. And then there is the industry, who would like to sell technology and drugs. And then there are the patients that only want to get better. But if all of these stakeholders are provided with the same information, what happens is that suddenly you turn their noses all towards the result of healthcare and the result that we want from healthcare. And this has proven on and on again to be the most important driver for change in the complex healthcare system. But it's time to speak the same language. Just that it is problematic that the economy and healthcare quality, different professions don't speak the same language. We have now introduced the first steps in e-health, and we realize that we suddenly have many systems that do not speak the same language. I'm not talking about the ability to transfer information between one system and another system. That's only technical. But I'm talking about the problem that we cannot convey qualified language between the system. It's called semantic interoperability. We must be able to access data across care levels, across diagnosis, across modalities of the diagnostics, across care organizations, across regions, and it requires efforts regarding interoperability. Remember that we have to abide to the law and the ethics. We have to have technology that's modular, so we don't have to buy everything at once, which means that we need to make sure that we base it on a sound semantic way of handling the information. Because if we have the same language to describe things, we will also assist the operational level, that is healthcare itself, in doing the same thing for the same problem. I think the example of the e-prescription hooked into healthcare that we just heard, and also the example of the hepatitis program. Both of those are really good examples whereby proper handling of the information on a semantic level really drives the change of behavior in healthcare, both for patients and for professionals. So the old model on the top here is really the doctor meeting the patient, and every time the patient meets the doctor, they get new orders and they really don't know what's going to happen. We know that the compliance is low, the healthcare seeking behavior is not affected at all in that type of clinical environment. If we instead use the same language, if we go to the lower end of this picture, if we go to the lower end and use care processes, and we provide the same information to healthcare and to the patient, then we can have a standard plan that we allow to vary for the patient, and then the patient is fully informed about the coincidence of my values and my goals with the goals of healthcare etc. And then you drive compliance towards medicine. Remember that the program that we are dealing with, one of the programs that we're dealing with is the program around blood pressure. And all of us know that you get blood pressure at one point in life, you have very few symptoms, and then you get a lot of disorders, which means that the compliance towards the medication around blood pressure is really difficult because you medicate something that has very few symptoms. And hence, the information part of blood pressure control is extremely important. And there, e-health tools with distributed information all the way out in the pocket of the patient in their mobiles is a really important way to drive health literacy in the population. Another good thing with working in a more planned way, in more process-oriented way, is that if you work in very in a different manner, like in this one here, you realize that you cannot get the data properly collected from the group. Whereas if you work with the same care plan for everybody, you know that the measurement points, they are really the same along the patient trajectory. And thereby you can continuously follow the way healthcare works out. The best example of in the world of this is in England, where they do psychological treatment in 1 million patient ongoing, about 1 million patient. And they have outcome measures every session for all those patients. So in the NHS system, it's possible to follow on a national level the quality that is delivered from healthcare in an extremely effective way. That's how one should do this type of support for healthcare quality. This is a Swedish example where the measures of inflammation level in the blood in patients with rheumatoid arthritis was pretty high 2004. We had patients that had ongoing destruction of cartilage, getting crooked fingers. And then the program with the quality register started, and you can see a gradual decrease. And about 2009, the global average for the all patients in Sweden, that's a population of 10 million people, was so low that none of the patients really have cartilage destruction. It's a fantastic development. And it also shows a blue line with the type of variability over time that you have when it's not organized care in one county in Sweden. And then they decided to put in the program, much like the hepatitis program here in Mongolia, they put in a program to organize it better, and suddenly the variation in treatment decreased. And ever since, almost for 7 years now, they've been better than the national average because they made an effort in educating healthcare of how to do it, supported with patient-reported data and laboratory data. So the idea with all this is that we should drive quality in the whole system. The profession should know what it should do in terms of processes. The patient should know what will happen and should be able to report the outcomes. The outcomes should be reported back in different quality levels, but should be reported back to strengthen the governance that is so impressive here in Mongolia, to strengthen the profession to do the right thing, and to really tell the patient that your opinion matters. It turns out that this is really important for the patient's ability to adhere to the policies and to really go ahead with their treatment. The future in healthcare is that the same patient, this is the age level, and this how old you are, and this is the fraction of patients, 0 to 100%. It turns out that and you're approaching this very quickly. We're already here, but you're coming here. I tell you, but I think your healthcare is better organized than ours, so you probably may do a bit better. But if you're as old as I am and have one a chronic diagnosis, you actually is more likely that you have 2 or 3. Which means that for a lot of the population, we need to be able to handle several care plans over time in order to be able to deliver healthcare. This is really qualified e-health that I'm talking about. And the reason is that the modern disorders, they come from the same mechanism and end up in several diseases because the pathophysiology is driven in between. I'm not going to go into detail in that, but it's a lecture of its own. But the important thing is that if we only treat things over here at the disease level, we can build healthcare for the world. If we include prevention in what we do, we can really do wonders over here. In our country, we spend 97.5% of all what we do in healthcare over here, and less than 2% of what we do over here. So my recommendation is to focus here in order to decrease that one, and you will have a much better health and a much better national economy. It is possible to have a care plan going from disease to health that you have in parallel with something that goes from illness to wellness, or to use that in prevention. So the information that we need to share in healthcare is not only the same terms, the same words for things, but we also need to share the idea of how we should perform this in sequence, that is the process or the care plan. Even if we split the patient trajectory in different sections, from pre-diagnosed to diagnosed to treatment to follow-up, it's still important that the same language and the same plan covers all of that. So, having worked with this in several different diagnoses in large populations and also in experimental settings, we have learned that it's possible to share knowledge across professional boundaries, healthcare boundaries, regional boundaries, and other types of knowledge boundaries. We can reach what we call world-class best practice, and I think you have shown here I refer back to it because I'm so impressed with the hepatitis program. You have really shown that it's possible with good information practices to run world-class best practice. If we have reached a language that with semantic interoperability, that is, we talk the same way about the same things, then we can reach all data for research and quality. That also means that we can get an IT architecture that is gradual in its implementation. An important thing, because IT stuff age very quickly. So we must be able to continuously invest in small portions and continue to do it, and thereby provide a disruption from within rather than shocking the system with putting a big computer in the center. And drive the implementation of the international quality measures is possible to do with structured data. So that's really 4 very important clues that we've gotten out of it. This is not done in a simple way. We need to, concept 1, we need to know any information that we collect that we do not give back to the person providing the information will be useless. The patient needs to get their data back, Healthcare need to get their data back. Healthcare is often not aware that they work in processes. So it's a schooling of healthcare, education of healthcare to become process aware around the patient. Not diagnose by diagnose, but the general concept of process awareness. Usually you have to do it, start with one, but once they get it, it's really smart, they get really quick. The third one is make sure that my actions, if I work in healthcare, really also influence the information I get. And number four concept, make sure that my plans that I do together with the patient really goes forward. So what is then ICHOM? ICHOM has published a number of these sets, and here I happen to illustrate that with the hypertension data set. That's about 80 different measures that you need around the patients in order to provide a quality measure of blood pressure control. If you look here, that's different dimensions here. That's the dimension of the patient experience, if the patient knows what's going on with the treatment, and also the disease outcome. That means the measure of the healthcare effectiveness in reaching each of the patients. So any successful dimension has several dimensions. Collecting this data is a process because you need to know what happened before, you need to know what happened in the intervention, and you need to know the outcome. And you need to collect that data continuously and project it back. But at least now we know we can actually serve the world with the success of the program if one uses these types of measures. It's really boring. It's just a number of words, etc. But that can be instrumentalized into a care process orientation. So what happens then? Well, we have the patient trajectory, where we have a data collection, where we take background data, intervention data, and outcome data. And we use the ICHOM measures that we collect locally in a quality repository that can report only group data to the international level. No individual data is transported. By doing this, we can actually report back in seconds how does your healthcare system perform in comparison to other healthcare systems. This is our vision and where we are going, and we have just launched a big program on that to get international benchmarking online. I'm going to skip this one because of time. So what does this international benchmarking do? Well, what we do is ICHOM, we publish plan definitions. This is what you should do. There's an international standard for that called FHIR that can be read locally, and every patient gets their care plan. Data is collected and put in the EMR or somewhere else. That data is then published locally. The data is not transported anywhere, it's published locally in a table. That data meets the harvesting algorithm, whereby we can see the group level data, the case correction data, etc. That is then reported to ICHOM, that immediately reports back the comparison with the international data. A really effective way of providing direct feedback to the whole system of how we are doing. And the pride you see in people when they start jumping up in the ladder is fantastic. It's really an important tool. Right now, and with report in January, we're doing 5 providers in different countries with different EMRs, where we have built a model dispatch, and people are really enticed about participating. So the concept is being tested right now, and we've done it manually before, and now we're doing it automatically with immediate report back. That's too complicated for me. One of the important things is that we need to consider one thing, and that is that the local capacity building in any country in the world, in any care system in the world, needs to be emphasized. You must own yourself the initiative, the competence, and the capacity to build the future locally. And work should be done in collaboration, not by continuous consulting from elsewhere. You need to build your own competence legally, regulatory, etc. around here, and also information-wise. That's why the presentation of the informatics or the information consortium initiative that we heard, it was really nice to see. One way of doing this and being able to shape the future in a modular way is to own the words that are going to be used in healthcare. Those words should not only be the words that you use, but also the plans, the sentences. This is how we should perform healthcare in a proper way. So by distributing the ICHOM plans, the different forms of terminology, the regional guidelines, and the local measures with the same terminology, you can actually handle this in a proper way. An important thing here is that I grade this one out. That means that this is knowledge that should be free to use for everybody. This is what we call the non-competitive space. Then we have this, the contact between healthcare and the patient and healthcare. Those contacts should also be in the non-competitive space, whereas people should compete very much around the type of tools that we have out in healthcare. Same thing for healthcare and patient information tools. That should be the competitive space. But the way we provide information from those local tools to the electronic medical record, to research, to the quality register, that should also be part of the non-competitive space. Doing it that way, you can build modular here, modular there, which means that you don't have to invest in everything at once, but you can actually build and build very quickly, because once you solve the technique once for this type of general map, you can scale it very quickly. So invest in the thinking of fundamental scalability to begin with. So in conclusion, care plans provide a strong basis for sharing of knowledge. That is the basis for modern healthcare. E-health effectiveness is dependent on semantic interoperability. Remember that remote harvest for quality and adherence to policies is possible. You don't have to move all data centrally. And reporting back continuous quality measures aligns the procedures. That means that you build a strong foundation for a strong healthcare that actually provide good numbers in public health. And by all means, good measures in public health is the same as a lot of happy patients. So by that, I wish you very much good luck with all the efforts and all the undertakings that we have been presented with as guests here. I really thank you for your warm reception. Thank you very much.
Thank you.
you.